So welcome all to the first edition of EAU TV at the 37th Annual EAU Congress, live from Amsterdam. We just came from the plenary session about viruses in urology, tentatively named Going Viral in Urology. So that will be a focus for this first episode of EAU TV, where we will focus on infections and viruses in urology. And for that, I am joined today by Dr. Philippe Spiess. He came all the way from Tampa, Florida, where he is the Chief of Surgical Services at the Moffitt Cancer Center. Phil is specialized in cancer, of course, but next to renal, bladder, also penile cancer. And of course, that's the reason why he was in this session today. And also we have Dr. Leila Scneidewind,
yes,
consultant in Germany, to be precise, the University Center of Rostock. And her specialty is infections research, something I know very little about. So I'm very glad you're here to join us. Let's start with those infections. So the session was called Going Viral in Urology. I guess it's a plenary session, so many of us wouldn't have thought that years ago that a plenary session in urology would deal with viruses only, because I think as urologists, we don't know much about it, and it's never been maybe that much in the spotlight. But I guess COVID has changed that, as many of us have been affected by it in our daily practice, I guess, but also, of course, at home and with our families. So I wonder, let's just start with that topic. What would be the main concern? What was the main concern the last 2 years, but what will be the main concern going forward for urological practice?
Yes, COVID pandemic has shown very widely how it can impact the whole health system, and it won't be the last viral pandemic in the world, I guess. So we can learn a lot from COVID, for how we make hygienes and how to treat our patients. And it was also part of the session how COVID impacted our health system and urology practice. But even in normal urology practice, there are a lot of viruses, and for example, hantavirus or the viruses of transplanted people, like in kidney transplantation, BK polyoma virus, CMA virus infection, EBV virus infection, and even in cancer, it's important, like HPV virus for penile cancer. And we also had talks about that. That's important, and maybe to other cancers. I think that we can learn a lot from infectious diseases, virus infection, even for immunological aspects in cancer treatment. So there's various topics in viruses in urology.
There are various topics. We're going to touch upon a few just now, because many viruses, but just stay a little bit on COVID. I mean, in our practice in the Netherlands, we've mainly seen the waiting lists, of course, as a problem, and it's still a problem. We're still trying to make up for those waiting lists for surgeries, of course. And, we're a little bit worried that there might come still a few small waves that might not be as extreme as the first one, but still it might lead to sick personnel that at least will not come to work, and which can also have their influence on the waiting lists. Is that something that you notice in Germany? And we also have someone from the United States, of course. I'm very curious also to hear how it's abroad. Yeah. But in Germany, I guess it's more or less the same problem?
No, it's the same problem. We have also waiting lists. We are still working on our waiting lists. We have less operating and surgery slots still. And this is a very big problem. And also the second big problem, I think, is vaccination. To get people get vaccinated, that vaccinations are good drugs with less adverse events. It's difficult to advocate the people. Right. And when you talk about antiviral drugs, we did also in the plenary, is that you always have to consider a causal therapy for viral infections is difficult to find, because when it's an antiviral drug, it always goes with adverse events, because the virus needs the host to replicate, and so you damage the host always as well. And so vaccination strategies are the best to fight viruses, or immune modulation therapies.
Yeah,
Yeah, I think it's always interesting to get different perspectives. What's being sort of seen across the world. I would say in the United States, there's no question this has been incredibly disruptive. I think what we've seen at our cancer center is that there is no question. I think we are now very sensitive to the fact that our patients are immunosuppressed in the cancer field. And, there's been obviously many publications which have shown from our center as well as others that our patient population remain highly immunosuppressed and potentially at risk of developing consequences from COVID.
Yes.
I think it's been a disruptor as well in terms of our staffing. I think, like I'm sure is being experienced across the globe, we have less nurses, we have less scrub techs, we have less people ultimately that are readily available for us to work in. And also, as you mentioned, people are getting sick from this, and probably not as sick as they were with earlier variants, but it is a disruptor. And so I think because of that, yes, there's been some delays. I think we have to be a little innovative as well in terms of taking care of our patients and prioritizing which patients should be cared for in a more timely manner. And I think one thing we talk about, I think was touched on by Professor Chappell today, is our supply chain has been disrupted. And it's interesting, as a surgeon and being involved as an assistant chief of our surgical services, is surgeons have had to be flexible in what equipment they use. So I used to like a specific material for certain cases, and there were several options. Now I got to accept there may only be one option in terms of what I can add. So I think it's made us have to adapt to a healthcare system which has evolved and really has been really strained for many, many months.
Yeah, well, let's hope that we had the worst and that we can learn some lessons to maybe prepare for future pandemics. Let's hope not, but we should be ready. And I think it has raised awareness, a little bit more awareness, and at least put some spotlight on viruses in general. So during the session, we also had some interesting things I learned at least when talking about oncolytic viruses or using viruses even as a treatment, but also other viruses. So you're as a virus expert, could you tell us, as urologists, what are the other viruses we should know about, and what are implications or maybe future directions? And well, can we see some more about viruses during the conference maybe? So.
Yes, maybe you should visit the EAU section meeting tomorrow, because it covers a broad spectrum of urologist infections, Fournier's gangrene, urosepsis, asymptomatic bacteria, and kidney transplanted patients, but the viruses. I will give also a talk about virus infections in urology, which all urologists have to know. And these are virus infections of making orchitis and epididymitis, like mumps, Coxsackie viruses, enteroviruses. So it's an interesting topic, the viruses. And I think there's a lot of research to have to be done on viruses in urology still, especially in the orchitis also.
And do you mean that to understand it better? Or
to understand it, which viruses are important? Do I need to treat them, or is it just symptomatic treatment? And one other interesting thing is bacteriophages, which are viruses which infect bacteria, and they can also be used for treatment in urinary tract infection, bacterial urinary tract infections.
I remember a little bit about having heard about that for a few years ago, actually, and it seemed very promising, and then it maybe be quiet, but how's the status on that?
It's a technical thing to solve, to generate the right bacteriophages in the put. But I think that they get better, and it's saving antibiotics because of resistant rates and stuff. It would be really interesting to use non-antibiotic strategies.
That makes it very promising.
Maybe, let's hope.
Well, we'll see. We'll keep an eye out on the other viral sessions this EAU. Well, moving on from these viruses we just spoke about, the second half of the session was all about HPV. HPV, well known for cervical cancer, of course, but we are urologists. So for us, I think the biggest implication of HPV is its relation to penile cancer. So we had quite an interesting session on that. First with a recorded lecture about HPV and a little bit focused on vaccination strategies and the way forward. Then I thought it was quite interesting. Unfortunately, the speaker could not be here in person, but in the Netherlands, what I've also found interesting that one of those studies already showed more or less the efficacy of HPV vaccine on male cancers. So it must be that they already started vaccinating men, or at least started vaccinating the population many years ago in some countries. But the Netherlands is actually a little bit slow, maybe, I guess, because we just started implementing the HPV vaccine in younger boys, or young men, as you will, this year. It's a few months ago.
Oh, okay.
So I wonder, how's that in Germany? How's that in the United States?
So it's very interesting. I think, I tell people I always have a very skewed view just because HPV is a high area of focus in my cancer center. We're putting a major PO1 grant, NCI grant, just because we have HPV scientists in the cervical and the colorectal, head, neck, and myself in the penile. And so I definitely think as a general community, healthcare community, I don't think we're necessarily doing a very good job promoting HPV vaccination. But I do think at our cancer center, that's a high area of focus. I do think in the penile cancer literature, like we were talking about, it's a big question mark is, like we were talking about is, yes, HPV vaccination for penile cancer has only been shown to decrease external genital lesions. Now, what does that mean for penile cancer? I think if we're really going to critically assess the data, I'd say big question mark there. I will tell you, as everything that we do in our healthcare system is you weigh the pros, you weigh the cons, and you look at the side effects. To me, I don't see major side effects, and no question, looking at the secondary favorable effects it has on cervical, head, neck, and rectal cancer, I will tell you that I think it's a no-brainer that we should offer it, and we need to promote it. And it starts probably at the pediatrics and at the primary care physicians, but us as well as specialists. And I will tell you, this is not evidence proof, but I have one of my melanoma surgeons who does a lot of cutaneous squamous cell carcinomas. I was in a lounge with him 2 weeks ago, and he looked at me and says, "Have you had your Gardasil yet?" I said, "Oh, I've got news for you. I'm about to turn 50 years old. I'm not going to get." He says, "Well, how much penile cancer do you take care of?" And I said, 5-6 cases a week. He says, "Well, what do you think of all that smoke you're being exposed to?" And again, not evidence-based, but I will say I've actually got my second Gardasil vaccination and have my third planned in a few months, because I do think we don't know the effects it has on healthcare providers. As us, we're in the operating room, probably using cautery and maybe using some sort of vaporization system to try to evacuate. But no question, we're exposed significant amount to these viruses and the potential consequences. So food for thought, not evidence-based, but definitely some active area, I think, for us to be thinking about.
Well, thanks. I feel a lot better now. I know my patients, I deal with penile cancer on a daily basis, and they ask me as well, of course, we know the benefits of the vaccination, or at least the potential benefits to prevent cancers when given at a young age. But of course, they are all wondering, now that I have HPV-driven cancer, where can I get the vaccine, right? And will it help? Well, I think unfortunately there's no evidence for that. We have to see, but it is interesting. I know that for cervical cancer, or at least for precancerous lesions, they are doing studies now to see if women that had such a lesion and were treated for it, if the recurrence rates are lower after vaccination. Well, we'll have to wait for that. Now I just tell my patient that they can get it, although they have to pay for it themselves. I don't know how the American healthcare system works, but it's probably the same situation.
Yeah, exactly. We have to pay for it. Either for myself or any of my patients, it's unfortunately not covered unless you fall in that higher risk male and female patient population. So I do definitely think until we have quality data, I think the healthcare system is so put the onus that you have to cover the cost. But the cost in the U.S. anyway is really nominal, just a few $100s for the 3 vaccines.
So last question about HPV. I mean, I've heard some colleagues, some people joke, right? Because I'm pretty involved in this awareness campaign for the vaccine now. So they tell me, well, your entire week is filled with penile cancer patients, so you're going to be out of a job after this vaccination. So, what's your thought about that?
I think you still got some fairly high job security, particularly, and I think, I say this all the time, I applaud, I think, of what's been done in Europe. I think it's a benchmark of what should be done around the world in centralizing care. So having, centers like yours, Oscar, and other centers in Germany, focus and really having a high area of concentration to take care of those patients. The bottom line is it's really been shown that it improves the outcomes of the patients, and also it makes sure that the right experts are seeing those patients, and whether that be multidisciplinary care or more refined surgery and management, I think it makes a difference. I think in the US, I think either there has started to be some efforts to focus, and I do think some ongoing trials will help identify centers of excellence for this, but I definitely think until we definitely have more impactful data that it has a benefit, I think you're probably good for a full career of research and clinical and surgical care.
Sure, yeah, that's a real comfort. But on the other hand, we also know that not all penile cancers are HPV related. Yeah. So we'll always have the HPV negative cases to focus on. So I think
you will.
I mean, as doctors, we all want to treat the patient, but it would be awesome if we can prevent like half of the cases. Maybe our successors will have problems having a full-time job maybe then.
Yeah.
So, well, we're talking about viruses, but also infections and antibiotics. You already touched upon it, that we all know that antibiotic resistance in the world, or resistance to antibiotics, as you will, is a big problem. I have South American roots, and I know in South America it's a crazy problem. Yeah. In Europe, we are maybe a little bit better at stewardship, although Europe, you also have a lot of differences between the countries. So an interesting study that has come out recently, I think, identifies the use of AI, artificial intelligence, to make the best choices in terms of antibiotics. Can you comment on that?
Yeah, it's a study of Tommasio Kai. He will present it here at the EAU, and it's really interesting. And I think this is one hot topic in fighting antimicrobial resistance, and to have better antibiotic stewardship approaches, because you use, it's a study about taking the right antibiotic choice in recurrent urinary tract infections, so patients who have treated with a lot of antibiotics, and you put all the big data in there, the local resistant rates, global resistant rates, country resistant rates, surveillance data, and the antibiotics used from the patient, and then you, the system will give you the right antibiotics, so the best empirical antibiotics. You still have to do a resistogram, but I think that approach with using KI will help to fight antibiotic resistance even more worldwide. I think it's a good and hot topic in our specialty.
Well, maybe not hot enough.
Yeah, maybe. Because
it's a big thing. You say such technologies might help in making the correct choice, but are they also investigated or being implemented to make the decision if you would have to give antibiotics, yes or no? Because sometimes I'm amazed. We work at a cancer center, so I only see cancer patients. But for instance, patients after cystectomy, when they have a urinary diversion, I mean, we all know that if you do a urinary test, it will always show bacteria.
It will always show bacteria.
The amount of patients that, I don't know, has abdominal pain, and the general practitioner does a urinary test, doesn't know this, so sees the urinary test and prescribes antibiotics. It's quite shocking, actually.
It's really shocking, but they are also working on this. But you have to, in this case, I think you have to also consider asymptomatic bacteria if they don't have symptoms. Okay, it's something different with neurological patients, but don't treat asymptomatic bacteria only in special patients. And it's even the question, like in kidney transplanted patients, they are immunocompromised, and I don't know if you have to treat them in an early phase. We don't know. There's no evidence for it. So that's also a question. Asymptomatic bacteria should not be treated except from special patient groups. So.
Well, you might hope that most urologists know this, of course, but
of course,
you also have a role to raise awareness in other healthcare providers.
It's raising awareness for antibiotic stewardship, and I think the best thing is to think about it, and then it will work out. Well, I think so.
Well, good to hear. How is that in the United States? I mean, is it a problem, antibiotic resistance? Is there attention for it?
So it's a very interesting one, as like you said, traditionally, hospitals have left it at the discretion of the individual clinicians to decide on antibiotics and who gets it and what given course antibiotics is given. I would say infectious disease stewardship has increased dramatically in recent months, and it's one of the quality metrics that's being assessed in many departments. And so people, I think, and clinicians have become much more familiar, aware, and I would say responsive in adhering to recommendations. Like you mentioned, asymptomatic bacteria, we still see inappropriate management of patients who have no symptoms based on that. And I think now that we do have, through the EMR, the ability to get some of that information and to drive in an evidence-based fashion, who should be getting it, I do think it creates opportunities. And like you said, AI, neural networks, deep learning, I think those are all great technologies where we can use big data and we can sort of really synergize that and really impact a lot of patients and educate clinicians.
Yes.
Well, all very exciting, and I think, we'll just have to see how it goes. Well, to end the session, I guess, a little bit, I think COVID-19 luckily did not prevent us from having this meeting now. So I'm very happy to see you all in Amsterdam, and I know a lot of people couldn't really travel because of several reasons, so there are also a lot of people watching the conference virtually. And to everyone here and to everyone watching EAU TV, I wish you all a very pleasant remainder of the conference.